Hello, everybody, and welcome back to BioSC 140 Human Physiology. This video will cover Laboratory 21 Cardiovascular Physiology discussion. So blood pressure is highest in arteries and lowest in veins. Remember, blood pressure or blood flow is dictated by pressure differences. Blood flows from high pressure to low pressure. Our pressure in our arteries is greater than the pressure in our veins, which is greater than the pressure in our right atrium. So that blood flows through our arteries, then to our capillaries, then through our veins, and then through our right atrium. So let's look at the pressure as blood flows through our circulatory system. So this area right here is our left ventricle. Our left ventricle pumps our blood up to 120 pressure on average. Typical person, 120 is a good typical number. And then that pressure needs to drop back down to basically zero because we need blood to flow back into it. And we need it to fill up that left ventricle. And then the ventricle contracts, systole, brings the pressure in the chamber up to 120 again, expels the blood into the aorta, and then relaxes again, brings pressure down, back down to almost zero during diastole, where it fills back up again. Now, why doesn't blood flow from the aorta back into the left ventricle? Well, the semilunar valves prevent that. There's a special, remember, heart valves ensure one-way flow. And whenever you have a valve in the heart and pressure is set up so that, like pressure differences are set up so that blood is going to flow the direction you want, the valve is going to be open. Whenever you have a valve in the heart and the pressure differences on both sides of that valve are set up so that blood is going to flow the wrong direction, that valve is going to close. So that's how we prevent backflow from the aorta into our left ventricle when the left ventricle is low in pressure. Right here we get into the AR arteries. So we have the aorta right at this first part. Left ventricle goes into systole, brings the blood pressure up, and pushes blood into our aorta. Remember, the aorta arteries are kind of like they're kind of like a balloon. They've got some elasticity to them. So blood gets pumped into them, they expand like a balloon, and then when the heart relaxes, when it goes to the diastole, that elasticity squeezes on the blood and pushes the blood forward, and it maintains a level of pressure as it contracts down to about 80, and by the time it gets down to about 80, the next heartbeat comes, expands it again, squeezes it down over time, expands it again, squeezes it down over time. Also remember what I mentioned last video. The reason why blood pressure decreases as you move through the circulatory system is resistance. The more resistance you encounter, the faster that pressure is going to drop. So here we have our aorta fluctuating between about 120 and 80 in a textbook case. And as we move into the arterioles and the capillaries, that pressure goes down and down and down all the way back to the right atrium. So right here, blood pressure decreases due to blood vessel resistance, friction with the walls. So venous pressure is relatively low. It is above zero, it's relatively low. 4 to 10 is a good range. I want you to be able to describe what we did in this experiment. We stood with our back up against a wall, and we put a mark at the height of our right atrium, which we guesstimate to be our armpit, on the wall behind us to kind of mark that level. We then hold our hand down by our side so that blood pools in the veins, and we see we have these distended veins, these swollen veins. We then raise our hand up slowly until we see those veins collapse. When those veins collapse, we mark the height of our hand when that happens. We then take the difference in height between where the veins collapse and where the right atrium is. Now, with this equation here, so it's height of venous collapse, that's height of venous collapse above the ground, minus height of right atrium above the ground, RA, divided by 13.6. Remember to have this number up here in millimeters. Remember to have it in millimeters. And that'll give you your venous pressure. The veins are going to collapse when the pressure in the vein is greater than the pressure in your right atria. Remember, pressure dictates flow, so when the pressure is dictating the flow is going to flow out of those veins, it flows out. Know how to calculate this, know the normal range. Atrial blood pressure is estimated by sphygmomanometry. So, indirect measure of ventricular pressure. So, we're taking the pressure of our brachial artery. Do you think the pressure in our brachial artery is the same as our aorta? Actually, as blood flows through our circulatory system, it's going to encounter resistance the further it goes, which is going to decrease the pressure. So the pressure here will be a little bit lower, but it's close enough. This is the standard place to take blood pressure. Another thing to think about is what arm you take it on. The further it travels, the further the blood has to travel from your heart, the more the blood pressure is going to decrease and be different than that of the pressure right when it leaves the aorta. So it's actually your left arm is actually going to be closer, if you remember back to anatomy class, to your heart, following your circulatory system, than your right arm. So you're going to get a better reading, a more accurate reading of what's actually going on in your heart and aorta if you use your left arm. So left arm is pretty standard. Typically in a clinical setting, not always, but a lot of the time, you'll actually write down what arm you take it in, to communicate that information to other healthcare providers who look at the records. So remember, rivers with smooth water, like the American River in Sacramento, like the Mississippi River, they don't make much noise. You don't hear them from a mile away. Really turbulent mountain streams in the mountains of California, you hear those rivers, from a quarter mile away, from half a mile away. Turbulent flow makes noise. Smooth laminar flow does not. Normally, our blood flows with smooth laminar flow. We're going to use turbulent flow and the sounds of turbulent flow and this blood pressure cuff to calculate, to estimate blood pressure. So we're going to pump the blood pressure cuff up high enough so that it stops blood flow, so that it completely collapses the artery. If there's no blood flowing through the artery, we should not hear any sounds distally to the blood pressure cuff. As we decrease the pressure in the cuff, there's going to become a point. Remember, high point is around 120, low point is around 80 for blood pressure. There's going to become a point where the high point, the systolic, is higher than the pressure in the blood pressure cuff, but the diastolic is lower than the pressure in the blood pressure cuff. When this happens, as the blood pressure gets higher than it is in the blood pressure cuff, some blood's going to go through, and as the pressure drops down below what it is in the cuff, blood will stop going through. That blood that makes it through is going to have turbulent flow, and you're going to hear it distally to the blood pressure cuff. The first time you hear the sound, we mark that, we remember that number as our systolic blood pressure. As we go down, as we decrease the pressure in our blood pressure cuff, we're going to hear those sounds every time, that turbulent flow sound every time, until the pressure in the cuff is lower than our diastolic pressure. Once the blood pressure cuff is lower than the diastolic pressure, there's going to be laminar flow. The blood pressure cuff is not going to contort the artery at all. It's not going to have any effect on the laminar flow. And so the last sound that we hear, we remember as the diastolic. We mark that as the diastolic blood pressure. These sounds have a name. They're called the Krotkoff sounds. Krotkoff sounds. Here it is again. Pressure's above systolic and diastolic, no sounds. The moment the pressure drops below systolic, we'll start hearing some turbulent flows squeaking through. Start hearing more, and eventually, once it's below, the sounds will go away. Systolic blood pressure is equal to systolic minus diastolic, SP minus DP. Pulse pressure is a good indicator of stroke volume. So stroke volume is, we've seen it before in this class. We're really going to talk about it in this lecture unit on the cardiovascular system. Stroke volume is the volume of blood pushed out of your heart every cycle, every contraction of that ventricle. So pulse pressure is equal to SP minus DP. Textbook numbers, 120 minus 80 gives us a pulse pressure of 40 milligrams of mercury. MAP, mean arterial blood pressure, aka MAP, is the average blood pressure over time. Average blood pressure over time. So MAP is homeostatically regulated. The average blood pressure is what your body responds to. It's what your body controls. It's maintained near a set point. That set point can vary. It represents the driving pressure of blood. It represents the driving pressure of blood. You know, you need pressure differences to move your blood through your body. You need to have that average high arterial blood pressure in order for blood to flow into your capillaries and into your veins and back to your heart. There's two calculations, two ways of calculating MAP. We've got 1/3 systolic plus 2/3 diastolic. Perfect. We've also got 1/3 pulse pressure plus diastolic. We come with the same number both ways. So whichever way you're more comfortable with, you may use. Expect to do some problems like this. In fact, I can tell you right now on the checkup quiz, there are some problems like this. Perfect. So right here we can see how MAP decreases as you move through our circulatory system. High in the aorta, lower in the arteries, lower in arterioles, lower in capillaries, lower in venules, lower in veins, and lowest in the vena cava. And it's this curve, your body maintains these pressure differences, and that's why blood flows the direction that your body wants it to flow. MAP increases with age, and sometime around 70, it tends to start to drop. Extended hypertension severely decreases life expectancy after 70. So every time your heart, when does your heart start beating? Your heart starts beating before you're born, and it beats every day of your life. It beats constantly. Your heart doesn't get a break. Your entire life, your heart doesn't get a break. The harder your heart has to work, the quicker things are going to go wrong with it. If your heart has to pump up to 120 pressure every single beat, every single day, compare the stress on that heart to a heart that has to pump it up to 160 millimeters of mercury every beat of every day. It's good to work out your heart. It's good to go for a jog for 45 minutes. It's good to get your blood pressure up while you're running and doing regular exercise. It's bad if you never let your heart rest because it has to pump up to 160 millimeters of mercury constantly every day, every beat of every day. That's why hypertension is bad. It's because it overstresses your heart. Your heart never gets a break. It's got to pump that arterial balloon up significantly higher every single beat, every single day. So extended hypertension severely decreases life expectancy after age 70. Keep your blood pressure in check. You want to work your heart out. You want to go for runs and do exercise. You don't want to work your heart out every moment of every day. So hypertension increases the risk of cardiovascular disease. It puts more stress on your system. Hypertension is 130 over 80, 130 systolic over 80 diastolic. Primary causes, 90% is idiopathic. Most of the time, it just happens. There's not really a good specific reason. About 10% are linked to other disease like renal hypertension. Renal issues would be the cause. Effects, it can damage arterial walls and lead to deposits. These deposits decrease elasticity. They do a number of things. You want your heart to not have to work hard. You want an efficient circulatory system, and having deposits in arterial walls, they can break off and cause issues, and they can also decrease the quality of that vessel and lead to some issues. Baroreceptors adapt to the higher pressure. So baro is like pressure. It's like your blood pressure receptors. These help regulate your map. They sense your map, your baroreceptors. Adapt to higher pressure. Causes cardiac hypertrophy. So an increase in the size of your heart muscle. If you increase the size of your heart muscle because you're regularly exercising, that tends to be a good thing. If you increase the size of your heart because it has to work harder every single beat of every single day, that's not good. It can lead to fatigue, and it can cause some other things. Certain types of the type of heart growth that happens from regular exercise, you can actually see differences in how the heart grows, and compared to the type of hypertrophy you get with high blood pressure. And the type you get from high blood pressure makes your heart less efficient. The type of hypertrophy you get when you exercise regularly is actually like good. It makes your heart more efficient, actually. So hypertrophy is not good if it's due to hypertension. Hypotension is systolic, lower than 90, and diastolic, lower than 60. And this can be fine if the person's asymptomatic. It can also not be fine and also be a sign of a pathology, something going wrong. All right, so arterial blood pressure, calculate MAP while sitting, rest for 2 minutes while sitting, take your blood pressure, stand up immediately, take it after 2 minutes of standing, and after 2 minutes of reclining. In the last video, I said hypothesize. What's going to happen? What's going to have the highest? What's going to have the lowest? And why? Well, let's get into it. So quietly sitting, resting baseline MAP. Sitting is actually going to give us the intermediate reading. So sitting quietly, 93.3 MAP. Standing abruptly, it actually drops a little bit right when you stand up. If you're standing for 2 minutes, then it actually raises up above where it was when you were sitting quietly. And when you're lying down, it is the lowest. So what's going on? When you stand up abruptly, has anybody ever stood up too quickly and gotten a little dizzy? You're like, whoa, what was that? And you stand up too quickly and you start to get a little lightheaded, but then you're fine after 2 or 3 seconds. Yeah, orthostatic hypotension, very common. Everyone's experienced it. It happens because of decreased venous return. So Your heart has to pump blood out to maintain blood pressure, right? Your heart has to pump up that arterial balloon, right, to maintain pressure. If there's no blood in your heart, how is it going to pump blood out? So if the veins don't return blood to your heart can't pump blood out, blood pressure drops briefly for a short time. That's what causes orthostatic hypotension. If your heart needs to pump blood out into your arterial system in order to maintain the pressure in there, that inflated balloon pressure. If the heart doesn't have blood inside of it, it can't pump blood out or enough blood out. If not enough blood returns to your heart, it's not going to have the blood. So you stand up quickly, it decreases the amount of blood returning via the venous system to your heart, which decreases the amount of blood your heart can pump out, which will decrease your MAP momentarily, take your body a few seconds to react and get back to where it was. Orthostatic hypotension. Baroreceptors, pressure receptors are stimulated, and they cause a baroreceptor reflex, which restores your MAP. So baroreceptors detect the sudden drop, and it takes a second or two to have your baroreceptor reflex kick back in and bring your blood pressure back to normal. So right here, person stands up out of bed, whoa, takes a few seconds. So that's why it drops a little bit when you stand abruptly. Standing tends to have does have the highest blood pressure out of the three options, and it's because your heart has to pump against gravity. There's more resistance. Your body requires higher pressure because there's more resistance to flow. When lying down, there's less resistance to flow. Your heart doesn't have to, you don't need as much pressure in order to maintain blood flow. So lying is going to have the lowest blood pressure. So this is the Starling forces. This is going to be a little bit of a study on yourself. I want everyone to go to at least the laboratory manual PDF that's on the Canvas site, page 122. It's within lab 121. So within lab 21, on page 122, in at least the PDF version of the lab manual that I posted, there's an explanation and a little worksheet on the Starling forces. I want you to work through that worksheet. So a little bit of a brief overview before you start. So capillaries are the site of exchange in our circulatory system. That's where things leave our circulatory system and come back in. We need to have a balance between things leaving our capillaries and things going back into our capillaries. We need to have a nice balance. If too many things leave, we can have extra fluid in our interstitial space, which leads to edema, which is not generally a good thing. NFP is net filtration pressure. Net filtration pressure is going to equal the forces that promote filtration. Filtration is leaving your capillaries. So filtration stands for pressure pushing things to leave the capillaries. So NFP is equal to the forces that promote filtration minus the forces that promote reabsorption. Reabsorption is fluid moving back into your capillaries. Filtration has two values that make it up. Reabsorption has two forces that combine to make reabsorption. So two forces combine to be the filtration forces, two forces combine to be the reabsorption forces. For the filtration forces, we have blood hydrostatic pressure, which is just like the local blood pressure in the capillary. And we have interstitial fluid osmotic pressure. That's the osmotic pressure of the interstitial fluid. The hydrostatic pressure of blood pushes fluid out. The interstitial fluid osmotic pressure pulls fluid out. The reabsorption forces are going to be blood colloid osmotic pressure, which is going to be your osmotic pressure pulling and keeping fluid inside of our circulatory system. And it's going to be IFHP, or interstitial hydrostatic pressure. So that hydrostatic pressure, like basically the blood pressure of the interstitial space, the hydrostatic pressure of the interstitial space. And that's going to be pushing fluid back into our capillaries. So you add these two forces up, you get filtration force. If you add these two forces up, you get reabsorption forces. If filtration forces are greater than reabsorption forces, we're going to have a positive number. We're going to have positive net filtration. It's going to cause fluid to leave the capillary because filtration forces are stronger than reabsorption forces. If reabsorption forces are stronger than filtration forces, we're going to have a negative NFP, which means that fluid is going to be reabsorbed back into the capillaries. So that's a brief little intro. Should get you started on this part D of Laboratory 21 in the lab manual, page 122 on the PDF copy that I provided. All right, everybody. As always, if there's anything at all that I can do for you, please let me know. Please ask questions, and I will see you in the next video.